Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today we have a very interesting guest, Chris Hutchins, CEO of the Hutchins Data Strategy. Chris, welcome to the program.
Well, thanks so much. I really appreciate the opportunity to be here with you.
So Chris, you and I don't really know each other. We met on LinkedIn. I saw that you launched a newsletter called the AI Health Pulse. Tell us a little bit about you, one, yourself, and two, what led to launching this particular newsletter.
Well, certainly. I've been around healthcare since I was really young. I worked in an X-ray department part-time on the weekends and vacations. My mom was a supervisor at a local hospital, and I had countless encounters with physicians and patients. And I recall at one point I was checking patients in at the front desk. It was directly across the hall from the emergency room, and from time to time you would see things that were a little bit discomforting. People have injuries and things like that. So that made me realize, you know what, I'm not going to be a doctor. I don't think I can do that. I don't have the stomach for it, honestly. But day after day, I continued to see physicians interacting with patients. And in particular, there was an orthopedic surgeon that I'll never forget. He was really frustrated because he couldn't find x-rays he needed for a case that he had to go into the OR for. I could not find them anywhere. And the longer I looked, the angrier he was. I ended up going upstairs and went to see his assistant and found them in his office. Brought them down to him. I never said a word about where I got them. He was still kind of steamed, but he started to walk around the corner kind of in a huff, and one of his patients was right there. His countenance completely changed. Most soft-spoken encounter I've ever witnessed personally between a doctor and a patient, other than my own experiences. And that really sealed it for me. Like, this is an extraordinary human being. The Hippocratic Oath really meant something to him. I just decided at that point, I want to find a way that I can contribute and I can support that profession, just because I saw it up close and personal. Before that in my life, I had allergies and things like that. I had plenty of opportunities to see doctors, but that was just a whole nother experience because I was looking at it from the outside. It wasn't my experience. It was someone else's. But that really struck a chord. So my career's been pretty much all about that. There's been some brief periods where I did some other things, retail. No matter what I did, everything kept bringing me back to the healthcare mission. And one thing led to another. I started when I was managing a small practice, just one physician and a physician's assistant. I did all the back office kind of work. I would answer the calls, talk to patients, did all the billing and that kind of stuff. But there was just an evolution over the course of, I've been saying 25 years for a long time, and I realized that's old. It's closer to 40 years that I've been around healthcare now, which is, it's mind-blowing when I think about it. But I've had great opportunities along the way to work with some extraordinary people, always people willing to invest time and teach me to do new things. I developed systems, built budget platforms, worked on a project implementing an editing system inside of what is now a GE tool, but back then it was IDX Systems was the name of the company that ran the software, but that's actually in the Athena Health world now. It was a process to essentially look for missing information at the time transactions were being processed, as opposed to after the fact. And I used to get this big stack of claims that I had to go through, 2 or 3 times a week. And there was a nice green bar paper that came with it, with all the exceptions that had to be edited and reviewed. This process actually moved all that up front. And that was an exciting thing for me, because I really got my teeth into IT development. From the first 15 years of my career working in one health system in New Hampshire, I got another amazing opportunity to work at Mass General Brigham Partners Healthcare at the time I was there. Extraordinary people I got to work with. You really can't go anywhere in the world and say Mass General Hospital where people wouldn't know what that is. And there's a lot of leaders and clinicians that are there in very similar ways. If you were to hear their names, they would probably be familiar in a lot of parts of the world. It's amazing to have the opportunity to be there. But Fast forward, the opportunity came for me to go to New York and be with Northwell Health. Unbelievable years there. I can't say enough about the extraordinary leaders that are there. Going through the pandemic is certainly nothing that any of us want to repeat, but I saw the best of humanity there. I saw that in my own team. I saw people stepping up. I think healthcare is that anyway, but when something like that happens and you get to see that people just transition and become a whole nother type of human being in those types of moments. I think you really do see the best of humanity there.
What led to AI health policy? AI it seems to be a big
Hmm.
jump from where you're at. Tell
Yes.
us a little bit more about the newsletter.
Yeah. So I've been working with data and analytics for a number of years, and AI has obviously become a hot topic. And over the last couple of years, as I was working in the health system here in Nashville, we had a number of different solutions that were either developed in collaboration with the organization, or some that I came across them through different contacts in my network or whatever. But the thing that was pressing me on the innovation side was the fact that I've seen many, many times solutions come in and they are really not going to address more than a small fraction of a larger workflow gap that we have. And it's just not sustainable. I can't have 25 solutions in this space that we really ought to have just one that's very well done and well integrated in all the places it needs to be. And being on the IT side, of things for a number of years, I know how fun it is to come up with solutions. And oftentimes we get creative. Once we get going and we see something that's really has promise, we'll just keep pressing it and make it more exciting and more fun and all that. But at the end of the day, it's the mission that we have to really keep ourselves tied to. That's why I've tried hard my whole career to make sure that as a leader, I have my team exposed to the clinical leaders. I have whatever opportunities I can have for people to really understand what their impact is. I try to make sure that we connect those dots. And the reason for the AI health post, so there's actually two reasons. One of them, I'm going to just be blunt with you. I've been getting some coaching, and I was told that I didn't have very long to put my first newsletter out, or I was going to be in some hot water. So I decided, you know what, this person knows exactly what she's doing, and I think I should take that advice. But the topic was one that I've been thinking about for a while, just because there are so many solutions out there. People are really concerned about, is it going to take my AI going to take my job? People are concerned about the ROI aspects of it if you're trying to implement. And for good reason. There's a lot of issues underlying the data sets being used that can cause real problems there. We'll talk a lot about that, probably almost more than anything, beyond just the human factor that we really want to make sure that our solutions are taking into account. Because if it's not taking friction out of the relationship between the doctor and the patient, or the nurse and the patient, then I question what is that we're trying to accomplish. Because we have two major problems today. One is there's a really difficult problem around access, people trying to get access to care. There can be a lot of reasons for that. But applying some of these technologies to where there's really major pain points, to me, that's the thing that's most pressing. And so the patient engagement with the physician, that friction that's there, administrative burden that we keep adding to the physicians and the nurses for that matter, even the support staff, the improvements that we make, the electronic health record. If you've heard me say this in other forums, forgive the repetition, but I think it does bear repeating. Back when I was getting my normal physical or whatever, a doctor had a dictaphone in his hand in the office. And sometimes they would dictate the note before you even leave there, but I knew that that's what they were doing. When they finish the visit, or maybe it's at the end of the day, they take that tape to a transcriptionist. The transcriptionist listens to it and types everything into a paper report. It goes back for review, and then eventually it goes into the record. We actually replaced the transcriptionist and made the doctor take that over when we improved his life by giving him an electronic health record. Right? And that was the first, only one layer that we added. Then all the quality reporting requirements, that the mandates that come along. Every time there's something that's added, frequently that results in the need to capture yet another piece of information. Now the doctor has to be thinking about that. It has to be added to the documentation, has to be added where it needs to be.
Aren't there different approaches, right? So and even the EHR, and that's I got into the market around 2002, before even the High Tech Act, obviously. And the idea here is that this EHR was supposed to be transformative, but it has been still just a different way of collecting a note, maybe
Right.
even harsher way, to your point of collecting a
Yeah.
note. But the challenge here is, I look at healthcare as it's a knowledge transfer type of business. And the knowledge transfer is you got the least informed patient, if you
Hmm.
will, around the science of the body, and you
Right.
have the most informed, the doctor. And how do the two share knowledge about what I'm feeling and how
Hmm.
to go about addressing how to,
Right.
and not just the symptom, but the problem, right? But we
Right.
have, to your point on access, I don't disagree at all. But we have developed today in 2025 a scenario where billions have been invested in the quote unquote transformation of the care delivery system. But we have more patients that are, we have an older, ager, sicker population today than we did
Right.
yesterday. That, as well as as my audience well knows, because I am repetitious in these stats, we have less doctors and nurses, and
Right.
access becomes a problem. 26 average of 26 days in the U.S. to even get an appointment. I am sick today. Just imagine what I'm going to be 26 days from now.
Right.
It leaves me to my own devices, if you will,
Right.
to find a different path to care, because I can't wait
Right.
26 days. And that,
Right.
interesting stat, age demographics, 18 to 44, 75 to 85% prefer a digital or a self-guided solution.
Right.
Ages 45 to 64, 60 to 70% are open to self-management, especially with trusted providers oversight.
Right.
And then 65 and over, 40 to 55% prefer traditional doctors directed care. Don't I understand why, but open to home monitoring. To me, I
Yeah.
read those stats because the market has to transform. And I think AI
Yes.
is that transformational body. Why? So I go back to my original point, healthcare being a knowledge based business. AI
Right.
is dangerous in some ways, but very beneficial in others. Dangerous is because I can go to ChatGPT, a very well
Mm.
known AI platform, as you know, and I can ask
Yep.
it a healthcare question. How many how many Tylenols can I take today? And
Right.
it'll give you the PI information. So if everything's
Yeah.
believable on the internet, and the ChatGPT is considered the internet to some degree,
Sure.
and I'm going to take those pills. However, if you don't ask that question in content, hey, I'm taking these other meds, the AI
Hmm.
needs to know you before it can actually answer that question.
Right.
And it may just say, hey, don't take any, because it
Yeah.
counter it it's as it's reactive to other medications you're taking and
Right.
things of that nature. So that's where I think AI is powerful, because it's knowledge, but it has to have knowledge of you as
Hmm.
well as
That's right.
the health pathways, but not just AI in and of itself. What are your thoughts?
No, but I'm glad you brought that up as well, because we've had this out there for a long time. In the early years, I thought WebMD was one of the first things that I remember seeing that just put all that knowledge out there for people to just go and inquire. And over the years, I've noticed that they've been very, very careful when you're looking up anything in terms of a condition you might have. More often than not, you're going to read the worst case scenario, which I think is probably intentional. I mean, I think I would probably want to do that too, just so that it drives somebody to go see the doctor. Don't just stop with your your questioning online. But the evolution of it to where it is now with ChatGPT, it is very, very powerful. But to me, that's why there's such an urgency around healthcare professionals getting engaged and figuring out how to say yes to this thing, and let's start figuring out where the guardrails are. Let's make sure that we're the ones informing the patient. We're educating them so that they understand. But we have to get into the forefront of it. And right now, we're not there yet. But there's an urgent need for us to do so. And I've told some folks recently, as a chief data officer, my intent was always to find ways to support the workflows that the clinicians had and try to find ways to get around all the barriers so that we can enable them to use the tools in a way that's beneficial to them. There's going to be plenty of other people, and it's their role, frankly, legal, compliance, information security. I need those people to do what they do, but they don't need me to try to find other reasons not to use the technology. I need to be a champion for the technology, and I also need to be a champion for those who are going to use it. If we do things well, using some of the technologies like ambient listening, for me, that's probably one of the most promising ones that I'm seeing right now, because it is freeing up time so the clinicians are getting more face time with a patient, which is entirely the reason that they wanted to go into healthcare, was that relationship with the patient and helping somebody. If we can continue to focus on those pain points, then we can release their time a little bit better. I also have to be very mindful of the fact that the CFO and the CEO are likely going to be thinking about capacity improvement and maybe more throughput, more volume, more revenue. And so it's important for people that are in my role as a former chief data officer. I need to make sure that I'm advocating and make sure that they understand our starting point is a deficit, meaning that we have already taken a good extra chunk out of a physician's life on a daily basis, that we need to return some of that back. Now, there can be some improved capacity, but there's a lot of things that get impacted by this. The relationship between the doctor and the patient being probably one of the most important ones. The doctor's happier, he's getting FaceTime doing with the patient. The patient's happy, they're getting FaceTime with the doc, and he's not staring at a computer screen every time he says something. He's not keying things while he's talking to me, right?
Right.
But if we can give back some of that time, I mean, the humanity piece of it that's so important to me, it has everything to do with even the physician's quality of life. I mean, I don't think it should be an abnormal thing for someone to go home and have dinner with their families once in a while. But we've kind of taken that.
Once in a while.
Yeah, well, I mean, they would actually be
I hear
happy
you.
with once in a while compared to what it's been like over the last few
No,
years.
I understand why you said that. I was poking at you. So, but I
Yeah,
hear you absolutely. So, if you look at AI as as a health assistant, which it can be, right? It's in your back pocket. It's
right,
always with you. If it knew your health information, so let's blow this out a little bit. If my AI had a connection to the QHIN, are you familiar with the QHIN and the national strategy? So, if I could access hypothetically all my data records from the QHIN, I could educate the my health assistant, and I can
that's
ask it
right,
questions, and it'll answer in context, as opposed to again the scenario with ChatGPT. But if I could then say, hey, let me enter a chief complaint, and
right,
let me walk and let my health assistant walk through a review of systems, making sure that the medical record is up to date. All my active prescriptions are recorded. I can ultimately that AI could ultimately propose potential diagnoses and propose a care plan for each diagnosis. The point, and I, as the patient, going back to the previous stat, I
hmm
could, um, those would be great self-management tools, right? How do I help alleviate? I can't get access to my doctor for 26 days, but how do I get access to knowledge that can help guide me between now and that 26th day, right? Or
right,
and then I could take that hypothetically, that soap note that my health assistant produced and send it over to my doctor. And maybe I can get elevated or prioritized a little bit more than waiting 26 days. Or I could just say, hey, I'm going to talk to a telehealth doctor. So I've reduced the intake time because the soap note's
hmm
already recorded. Now the
yes,
doctor, when it talks about especially with trusted provider oversight. The doctor always makes the final decision, no doubt, in my opinion. Right.
Yes.
So I could, I could ultimately see a telehealth doctor and say, hey, here's the soap note, and you tell me, ask me some more questions if you want, if you so let's get to the
Right.
diagnoses and let's get to the right care plan. And the value of the that health assistant is that, hey, I know you, and
Yes.
therefore I can send health reminders not only about take your meds, but hey, it's for men of certain age, it's time to go get that the colon check. And
Right.
for females, it's a lot of different health reminders can come. So to your point earlier about, hey, I um I'm younger in my years, right? And but that having access to that knowledge much earlier in the life cycle versus waiting till you're 65 and over and develop and having developed a chronic condition puts so much onus on the system, because that's where 90% of our spend is, right? 65, and with all due respect, I'm
Yeah.
not criticizing, I'm not, just stating the fact. 90% is of our healthcare budget is focused on chronic conditions. How do we
Yes.
help use AI to mitigate the development of those chronic conditions? Because we're educating
Hmm.
them, we're engaging them, and we're driving better outcomes much earlier in life,
Right.
prior to 65. Your thoughts?
This is an important one. I think there's a couple of different challenges with this. So I think we absolutely have to make sure that we're pushing the envelope and trying to be out in front and proactive with this kind of transition. And this is where it gets a little dicey. You mentioned chronic conditions. Well, we do tend to treat symptoms more so than we do anything else. And prescriptions are the name of the game. And doesn't come across well, I'm sure, but that's what we're talking about here. It's a whole industry. And that in and of itself is a force that we've got to grapple with here. Because if we can't change some thinking and change some priorities there, we're not going to make the progress that we need, because we're still spending trillions of dollars on advertising that are driving people to these behaviors that are creating the demand for these medications. We're actually
Yeah.
evolving and discovering new diseases all the time because of all the quote improvements we're making, and we're driving people to these behaviors, and they're using new products. What's going on now, and from a regulatory standpoint, in the healthcare systems, in the government structures with the new physicians that are kind of at the helm, they're they're talking about some things that are just really kind of common sense, removing things from our food supply that we've been doing really poor things to ourselves. We're not helping ourselves. But this is a bigger thing than just the intent of clinicians, because I don't think I've met one. If I would be shocked if I met one that didn't have the best intention and want the best outcome for their patients. Of course they
Yeah.
do, but you have whatever tools you have available, and our focus has been heavily in the medication space rather than the kind of the whole health kind of approach, where we're trying to figure out what are the root causes, and let's figure out how do we help somebody to start to take control in
Yeah,
their
I mean,
life.
at the end of the day, it's, you treat a diabetic, and it's about how do we get them to remission. You treat a person
Hmm.
with obesity is how do we get them. I'm a Biggest Loser model type of guy, right? I don't know if you remember that show years back, The Biggest
I
Loser.
do.
I walk in with a bag of pills, obese and everything else, and then I walk
Hmm.
out with no pills and
Right.
150, 200 pounds lighter. Doing that over time, not with the intensity of The Biggest Loser, but doing that over
Right.
time is let's not treat the symptom of, hey, can you stop eating that Kentucky Fried Chicken? With all due respect to Kentucky Fried Chicken, which I love myself, but but the point
Right.
is, can you stop eating that so frequently? Can you lose a little bit of weight? Can we?
Right.
How do we put diabetes in remission versus thinking with type 2 diabetes you got to die with it, right? There's
Right.
just so many things. we're running out of time here. I got a minute left. Tell us a bit about where I can find the AI Health Pulse.
Well, you can find it on LinkedIn. It is open. I'll be sending out a teaser probably later today or tomorrow for the next episode. But if you want to find me on LinkedIn, my name's Chris Hutchins. You can also find my company's page there. It's Hutchins Data Strategy Consultants. But you're going to be hearing a lot more, I think, in the coming weeks. We'll probably start doing some interviews along this line, understanding how people are thinking about AI. I'm hoping I can get. I know I'm speaking with a physician after you and I finish here this morning, because I really want to hear from the physicians where their pain points are. But we're going to focus a lot in AI Health Posts on where are the pain points and where are the things that we need to be really shining a light in trying to direct our development efforts.
Awesome. Chris, I appreciate you joining us as a guest. It's been great talking to you. Hopefully we'll have you on soon again, and have a great day.
Well, thanks so much. You too.
That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.